Hi, my name is Vanessa, and this video will be on the disease process of syndrome of inappropriate antidiuretic hormone. According to our textbooks, this health complication can be defined as the overproduction of antidiuretic hormone or the release of antidiuretic hormone despite normal or low plasma osmolarity. This leads to the body retaining too much water and eventually leading to kidney damage. This health complication usually occurs secondary to a current health complication. The current health complication or causes of this disease is or can be any of the following: medication usage, surgery, HIV infection, pulmonary disease, hormone deficiencies or administration, or it can be hereditary. The subjective data that a patient with syndrome of inappropriate antidiuretic hormone secretion will experience are low sodium levels and a low ECF osmolarity. This will eventually cause cerebral edema and can lead to other serious issues. The cerebral edema is caused by the water moving into the cells. Depending on how bad these labs are affecting the patient will determine the other signs and symptoms the patient experiences. With acute hyponatremia, the patient will feel nausea, vomiting, and malaise. As the sodium levels continue to drop and become more severe, the patient will have a headache, lethargy, muscle cramping, and irritability. These sodium levels can eventually drop so far to where the patient experiences seizures and a coma. For the diagnosis of the syndrome we are talking about today, there is clinical criteria that was made. The first one being a serum sodium level less than 135, a serum osmolarity less than 275, urine sodium greater than 40, urine osmolarity greater than 100, and then there has to be an absence of clinical evidence of volume depletion, which is normal skin turgor, blood pressure within the reference range. There needs to be absence of other causes of like hyponatremia, such as adrenal insufficiency, cardiac failure, renal disease. And lastly, there is a correction of hyponatremia by fluid restriction. This information I got from the National Library of Medicine. Other tests for this syndrome are going to be your serum osmolarity, serum sodium, urine sodium concentration and osmolarity, your BUN and creatinine, your thyroid profile, your serum cortisol, your serum potassium bicarbonate and chloride, your fasting lipid profile, and your liver function test. Before diagnosing a patient with this syndrome, a clinician has to rule out hypothyroidism and adrenal insufficiency first. According to the National Library of Medicine, the treatment plan involves correcting the sodium levels and correcting the underlying issue with the patient. The goal of the sodium correction should be more than 130. The treatment for this usually depends on the signs and symptoms and how severe they are at presentation. One medication that you will be giving is diuretics, such as furosemide, because that combined with salt tablets can help with the urine concentration and increase the water excretion for the people. It is important to be educated on the types of saline you might be giving your patient: isotonic, hypotonic, or hypertonic. The isotonic solution is not going to be able to correct the hyponatremia, or it could be, but in some cases it might not. So it is important to use a solution with an electrolyte concentration greater than the urine electrolyte concentration. With the solution, if the rate is going too fast, this can cause an osmotic demyelination of the central nervous system, leading to severe fatal complications. Patients presenting with confusion, delirium, those are patients who are prioritized. We suggest hypertonic saline infusion for the first couple of hours for a more rapid fix. And with this rapid fix, it is important to keep checking the sodium levels. Another medication that can be given to these patients is a vasopressin receptor antagonist. These medications are great at correcting hyponatremia and the baseline mental status for patients. Other treatment can just depend on the problem. If there is a tumor that is causing overproduction of ADH, surgery may be suggested. If medication is the cause, the dosage might need to be changed first. But mainly the doctor will suggest just limiting fluid intake. This doesn't just include water, this also includes coffee, tea, juice, and soda. In cases of medical emergencies, this is when the saline solutions will be used. And there are medications that can be given to block the effects of ADH. They can be given as a pill or IV. Other than all that information, other possible complications can be decreased consciousness, hallucinations, coma, brain herniation, or even death. As a nurse, the teaching you should do is to mainly teach your patient the signs and symptoms of hypo and hypernatremia and when to call a physician or the emergency room. And if there's any medications involved, just knowing those side effects, when to take it, the dosage, and the route.